speaking about doing cervical laminoplasty without hardware. And as we all know, the open-door laminoplasty is not new. Introduced by Hirabayashi back in the 70s. And it's a common procedure. Has been reported to be as effective as laminectomy and fusion to treat myelopathy. Between those two procedures, they have largely replaced, for many surgeons, they have replaced regular plain laminectomy. But in the past 20 years, there has been a gradual increase in the use of hardware, plates, screws, and little allografts or a variety of pegs, with increasing cost. However, according to various reviews and also our own study, there is no apparent benefit. We did a study that actually started in my previous institution at the University of Chicago, where I ran a prospective registry. And for a period of time, I was doing routine CAT scans on those patients. So immediately post-op and then at 6 months. I kind of quit doing it, but there happened to be a series that overlapped in time with the prospective randomized prospective registry that allowed us to have a segment of consecutive patients that had not only excellent patient-rated outcome registry, independently collected by a special registry manager, but also CAT scans. So we had an unusually rich amount of information about that series. So that population had 13 females and 19 males, with average age of 66 years. And we performed the procedures during this period, and after that was only follow-up. And most of those patients were, as you can see, older and had many comorbidities, and average BMI was 30. It's not that I selected those patients. Working at hospitals that treat poorer areas in the United States, it usually comes with very high rate of obesity. And patients, many of them were myelopathic, and they were discharged to home or acute rehabilitation. So that was kind of a unique opportunity with a high follow-up rate. The indications were multi-level stenosis, more than 2 levels, or other reasons to avoid anterior approach, and the presence of cervical myelopathy or combination of myelopathy and radiculopathy. Contraindications are fixed or irreducible kyphosis. And of course, the patient needs to be in acceptable medical condition for general anesthesia and positioning. And for the residents or juniors who have joined the presentation, fixed kyphosis doesn't mean the patient is fixed in a kyphotic position. It just means kyphosis that on the flexion or extension X-ray does not reduce into at least straight alignment or hopefully lordosis. So that's irreducible. So my approach was very simple: classical midline posterior incision, C3 to 7. In this series, I always include the C7. Going only to C6 is also possible, but for some reason, in my experience, the long-term success has not been quite as good. And we dissect muscles to mid-facet and try not to disrupt the facet capsule. Remove spinous processes, preserve C6 and 7 for structural autograft, drill one side, the worst, in the gutter completely, and the other partially until it can bend. This is the finesse of laminoplasty, but it doesn't matter whether you do it with instrumentation or not. Then we create supporting pegs from C6 and C7 and insert them under C4 and C6 respectively. Other levels remain open with the 2 supports. That's an important point. You don't need to put it under every level. As long as there is ligamentum flavum and other tissues in between the remaining lamina. And then, important note, I always put the patient in a hard cervical collar for 3 to 4 weeks as muscle support to prevent early kyphosis and excessive neck pain. It's not for stability for bony fusion. That takes much longer, but really to prevent excessive pain, and early kyphosis due to weakening of the muscles. In that study, there were no major complications, no infections, dehiscence, or any graft movement or dislodgement, and specifically no C5 palsy. Again, laminoplasty without hardware is a specialty thing. It's not something that fits all patients. A lot of patients have deformity, kyphosis, and other reasons to do a laminectomy infusion. But with I did more than 200, probably about 230 or 240 cases so far. So it's a little bit of a niche application. But whenever I chose to do laminoplasty in the past, I would say 12 or 13 years, I've done it without hardware, whereas in earlier years, I used to put hardware as various hardware. One dehiscence in a 77-year-old female who eventually was found to have zinc deficiency and had rapid healing with zinc and protein supplements, one infection without dehiscence, and 2 cases of kyphosis progression, one asymptomatic and one with severe chronic neck pain that was not relieved by fusion. Both of the patients at lower lordosis were borderline indications, and also did not, one of them did not cooperate with wearing a collar. But at this time, I would have fused them rather than go with laminoplasty without fusion. Here is an example of a CT scan 1 day post-op. Axial at C6. Well, that's on the left side. On the right side, it's 6 months post-op. Exactly same patient, exactly same cut. So what we can see is that this autograft integrates very nicely. This kind of smooth contour of the fusion is typical of this type of PEG autograft. It remodels to fit the patient's topology, which you cannot see, of course, with allografts, with cadaver bone or anything else. In that study, we could see the gradual improvement of visual analog scale follow-up scores for neck pain, which is quite impressive. NDI, PCS, that's the SF36 PCS scores, but the mental did not change. Mental remains the same. We also have a perceived outcome in which here it is. That's a better thing. So we have the early perceived outcome was it was actually a patient questionnaire that asked them how are they doing compared to before surgery. Overall, their overall condition. And in the first evaluation at 3 months, everybody was happy, had at least some improvement. And then at 1 year, you can see that some people had worsening, significant or very significant worsening, but the majority still perceive that they are much better than they were before, or at least somewhat better. So it's a kind of a 7-point scale of change in their condition. Numeric scores also improved, and the main conclusion is that cervical laminoplasty without hardware can be a successful treatment for cervical myelopathy and radiculopathy. I have some observations to share. Is first of all, the patients experience an improvement in their pain score on the VAS, including neck pain. The results of the VAS for neck pain are better than what has been reported in the literature for open door laminoplasty procedures. And they observed an average improvement of 1.15 points on the VAS of neck pain. And I think, I speculate that early use of a collar has contributed to that. Improvement in neck pain is not a goal of laminoplasty or any decompressive surgery for myelopathy. It's not something we necessarily expect, but it's a good bonus. Our patients had an improvement in neck pain despite not performing a muscle-sparing dissection. And the VAS was decreasing over time. Performing laminoplasty without allograft and hardware saves on cost of the procedure. without apparent detriment to the outcome of the patients. I do not believe that laminoplasty with hardware, with plates and screws, would prevent poor late outcome due to kyphosis. So you just need to watch very carefully what the indications are. The mechanical part, the biomechanical part of the laminoplasty is the same. It is a laminoplasty. The question is, of course, the placement of little plates and screws that were not available in the first generation, the first 25 years, were not done, and then became very popular, and I claim for no particular medical reasons. The rate of fusion at the second scan, usually at 6 months postoperatively, in that series was 100%. And again, I'm hard pressed to continue after that to subject every patient to a CAT scan. So I usually do just an X-ray or flexion extension X-ray at this time because fusion has been a very high rate. And again, it's hard to justify the cost and the radiation of repeat CAT scans routinely for those patients. And you can see an open canal pretty well on a regular X-ray in those patients. And there were no reclosures. And that's one of the first questions. You didn't put any hardware, wouldn't it reclose? And the answer, no, it doesn't. So basically, that's it. Thank you very much.
Thank you. Thank you very, very, very much.